absolutely zero fluff. Here's our roadmap for today. 1. Classification. 2. Management. 3. Key clinical pearls. 4. Classic exam traps. And 5. A quick recall question. Let's dive in.
Section 1. Classification, uncomplicated versus complicated. So let's break down these two main buckets, because the World Society of Emergency Surgery divides this disease strictly along these lines. When we say uncomplicated acute appendicitis, we literally mean the inflammation is strictly confined to the appendix itself. It's simple. There is absolutely no perforation, no abscess, and no diffuse peritonitis. On the flip side, the complicated category means the disease has progressed. We're talking gangrenous appendicitis, a perforated appendix, a periappendicular abscess, a phlegmon, or diffuse peritonitis. Getting this clear dividing line down cold is the foundation for everything else we're going to talk about.
Moving right along to Section 2, management strategies and targeted treatment pathways. Okay, so how does this actually change what we do for the patient? Well, as you can see, the pathways diverge sharply. For uncomplicated cases, your standard go-to treatment is a laparoscopic appendectomy, though, in some very selected patients, you might consider an antibiotic-first approach. Contrast that with complicated appendicitis, specifically if you've got a perf or diffuse peritonitis. Those scenarios demand urgent operative source control. That usually means getting in there for a lap appy if feasible, doing a peritoneal washout or suction, and of course, hitting them hard with antibiotics. Now, here's where it gets a bit tricky and requires some real clinical nuance. Dealing with an abscess or a phlegmon, notice that we don't just automatically rush them straight to the OR. Management here is highly dependent on a few key factors. How stable is the patient? How big is the abscess? What's the local expertise like at your hospital? And is the abscess even accessible for drainage? Depending on all that, your options might just be antibiotics, or you might go for image-guided drainage, or even an interval appendectomy in selected patients once things finally cool down. All right, Section 3, Key Clinical Pearls. Time to master the distinction. If you remember only one thing from this entire explainer, make it this fundamental rule. I honestly can't emphasize it enough. Uncomplicated means inflammation is entirely confined to the appendix. Complicated means gangrene, perforation, abscess, phlegmon, or peritonitis. Literally burn that into your brain right now. Committing this specific quote to memory is going to guide almost all of your diagnostic decisions on the wards. Here's another huge pearl for you, the appendicolith. Remember earlier when we talked about that antibiotic-first approach for some uncomplicated cases? Well, watch out. If you spot an appendicolith on their imaging, you need to be highly vigilant. This specific finding significantly bumps up the risk that an antibiotic-only strategy is going to fail, and it also raises the recurrence risk. Basically, it's a huge red flag that might push you away from antibiotics and straight towards standard surgery. Next up, Section 4, Classic Exam Traps. Let's make sure you don't get fooled. Board examiners absolutely love to test the fine lines between specific definitions, and there's a massive difference between two commonly confused terms, a phlegmon versus an abscess. A phlegmon, or an appendicular mass, is an inflammatory mass, but crucially, it is without a well-formed pus collection. An abscess, on the other hand, that is a localized collection of actual pus. This is a classic binary trap, so definitely don't let them trip you up on the phrasing during a clinical vignette. And here is another major distractor they love to use, age. Listen, perforated appendicitis with diffuse peritonitis is always complicated appendicitis, period. Do not let a test question trick you by throwing in details about the patient being a toddler or a 90-year-old. Diffuse peritonitis equals complicated appendicitis every single time, regardless of age. Don't second guess it. Finally, Section 5, a quick recall question to really test your knowledge. All right, rapid fire time. Let's lock this into your active memory. A patient has acute appendicitis with a preappendicular abscess. What is the WSES classification? Take a second, think about that binary framework we just established, and categorize this in your head before I reveal the answer. Did you say complicated acute appendicitis? If so, you totally nailed it. Because there's an abscess, the disease is no longer strictly confined to the simple, non-perforated appendix. Now, as we wrap up this explainer, I want to leave you with a thought. How will mastering these strict binary surgical classifications, relying on exact definitions rather than just, a gut feeling, change the way you quickly and confidently triage your very next acute abdomen patient on the busy wards?